Welcome back to AMC Decoded. We are moving on to question number 4. You know, they say salt is the spice of life, but in medical examinations, sodium questions are usually just the spice of my nightmares. I think 90% of my gray hairs are caused specifically by the hyponatremia algorithms. But jokes aside, today we are tackling a concept that, to be honest, does not appear frequently on examinations. It is a rare type of question. However, this is exactly why it's dangerous, because it looks like a very common condition. And if you treat it like a common condition, you might actually kill the patient. Let's see if you can spot the trap. The question is, what is the most appropriate initial management of this patient? Now, I want you to pause the video right now, read the vignette, and lock in your answers. The answer is B. Intravenous infusion of 0.9% saline. Let's try to decode this. The key to answering this question correctly is looking strictly at the volume status of the patient. Here is the trap. If you only look at the numbers, cerebral salt wasting, that is CSW, and SIADH look identical. Both have low serum sodium, low serum osmolality, and high urine sodium. But you can differentiate them by looking at the patient physically. Blood pressure and pulse. The patient is hypotensive and tachycardic. That indicates hypovolemia. SIADH patients are euvolemic. Now, let's look at urine output. Our patient had massive polyuria. SIADH patients usually have low or normal urine output. Blood urea nitrogen. The BUN is elevated, suggesting pre-renal dehydration. So, the diagnosis is cerebral salt wasting. This occurs typically in the setting of CNS disease, most typically subarachnoid hemorrhage. The pathophysiology is simple. The injured brain releases natriuretic peptides like BNP. This tells the kidney to dump sodium. Now, here is the key concept. Where salt goes, water follows. So, the patient urinates out all the salt and all the volume, leading to hypovolemia. Let's reinforce this comparison because even though it's rare, it's higher. Look at the list. Hyponatremia, high urine osmolality, and high urine sodium. This happens in both conditions. Even uric acid is low in both. So don't rely on that. The only distinguisher is the volume status, wherein SIADH, the patient is euvolemic, and in CSW, the patient is hypovolemic. Now, let's talk about management. Since the patient had cerebral salt wasting, she is hypovolemic. The treatment goal is to restore that volume. So, the initial therapy, isotonic saline, it restores the volume and shuts off the ADH response. Now, pay attention to this warning. Fluid restriction is the standard treatment for SIADH, but if you fluid restrict our patient with CSW, who has a subarachnoid hemorrhage and already in shock, you will increase the blood viscosity, and this will precipitate cerebral vasospasm and cerebral infarction. You could stroke out the patient. That is why option A is dangerous distractor. Now, let's quickly roll out the rest of the options. As we said about option A, this is for SIADH, and this patient, it is contraindicated. Option C, 3% hypertonic saline. This is reserved for severe symptoms like coma or seizures. Our patient is drowsy but follows commands, so that means it's moderate. More importantly, she is in shock. You don't treat shock with small boluses of 3% saline. You need volume resuscitation with normal saline first. Option D and option E. Dameglocylin is used for chronic SIADH and desmopressin is used to treat diabetes insipidus. Both are wrong here. So, to recap the golden rule for question number 4, if you see a patient with hyponatremia and high urine sodium, check the blood pressure and pulse immediately. A normal blood pressure plus moist mucosa. That means it's SIADH. So you have to restrict the fluid in those patients. If it's low blood pressure plus tachycardia plus polyuria, that means it's cerebral salt wasting. And you give saline to this kind of patients. Thanks for watching question number 4. If you found this helpful, hit like and subscribe to AMC Decoded. I will see you in the next video.